Yes, doctor.
All right. Okay, a very good evening to everyone. So it's a very difficult time to give a lecture, especially around 4 p.m. on a Sunday evening. So I hope I won't bore you all much, and hopefully I can get this done as soon as possible for you to leave you out of agony. All right. Thank you to MAC for allowing me to present regarding emergency care and aesthetic medicine practice. So let me go to my slides. Okay, disclaimer, I need to thank Dr. Noor Abdul Karim, emergency physician from UITM, who had contributed some portion of this presentation, which I took over from her. And the objective of our presentation today, our lecture today, will be to cover the basic life support, list and manage common aesthetic emergencies with regard to procedures, and the management of minor emergency situations. My talk will be outlined into two parts. We will cover the basic life support. Basically, it's CPR in the first part of the presentation, and followed by management aesthetic complications on my second part, which will be further divided into general complication and specific complications. So I'm sure, since this is an online platform, I won't be able to fully see to all my participants. Usually the first question I will throw up to them is, how many of you all still have a valid basic life support certificate? And a fair amount of the time, I think mostly about 50% will still have a basic, a still valid one, but the other 50% have long lost their basic life support certificate. So I would be, it will be wise and it will be best for you to renew your BLS in accordance to the latest guideline. What is actually basic life support? It's actually a foundation of saving life. This is done when a person gets into cardiac arrest. So it is aimed at providing a very high quality and effective chest compression, and which would manually supply oxygen to the brain and also to the vital organ, also including to the heart. It is found that an effective CPR can provide about 10 to 30% of the normal cardiac output. So this is when you're attending a basic life support course, this will be a chain of survival. This picture you will always see. So if you really look into it, it has 5 chains: early recognition and activation of the emergency response system, followed by immediate high quality chest compression or CPR, followed by early rapid defibrillation, and transfer the patient to a basic or an advanced medical care facility, and to provide the advanced life support at the nearest post-arrest care. So as a lay person, the first 3 circles that just a moment. Okay, these first 3 chains of survival will be more appropriate for a layman, and the other 2 chain of survival mostly is for advanced cardiac care. So why did we bring up this topic is, you will not know when would your patients develop cardiac arrest. So it is very essential for you to know how to provide the first aid in the very first few moments of its cardiac arrest, so that this patient will have a very good outcome and recovery later. And if you realize, the first 3 chain is provided by a lay rescuer, whereas the 4th and 5th chain, you need to transfer the patient to a better care, like emergency medical services, to the emergency department, and if it's needed, to the catheterization lab, and also followed by a post-arrest ICU care. So there are 5 links that you need to be aware of. First is early recognition, and you need to activate the emergency response system and start early chest compression. If the rhythm is shockable, you need to provide early defibrillation and transfer the patient to an advanced medical care facilities. I'm very well aware and very sure that you may have the basic resuscitation tools in your clinics or wherever you practice, but further or advanced care could not be provided in your clinic, and it is not advisable to keep patients with cardiac arrest in your clinic and to treat them. It is best to refer them to a tertiary center with appropriate cardiac lab or cardiac care facilities. So how do you activate an emergency response system? Okay, in our country, we call for 999. Okay, if it happens with outside the healthcare facilities, it could happen anywhere in the mall or so, or even if it happens in your clinic, which is outside the hospital, you can ask your nurses to call for 999 for help. Okay, you need, if let's say you're attending the patients, definitely you need a second person to put the call, and what the person who needs to know and needs to do during the call is to provide clear description of the situation, the location, and also the contact number. This call of yours on 999 will be transferred to a crisis center, and this crisis center will then delegate the phone calls to an appropriate institutions within the nearest facility of your location. And the person who is conveying the messages should follow all the instruction from the given by the crisis center, and do not hang up the phone until being instructed by the dispatcher. So how do you recognize a cardiac arrest? Usually the patients will fall on ground while talking or anything, or they become less responsive, or suddenly they fail to breathe, or they show any signs of abnormal breathing. So as all of you all have seen, the first thing you do, you tap the patient's shoulder and you ask them, hello, hello, are you okay? Okay, trying to establish the consciousness of this patient. Next, the thing that you need to do, you need to go and detect for the pulse and breathing. Commonly, we all go for the carotid pulse, and if let's say there is no breathing, there is no pulse, you start the CPR immediately. Okay, there are two guidelines which commonly used. Okay, one is the 2010 guideline, and the latest one is 2015 guideline. So what is the basic differences is, in the 2010, we always go for airway, breathing, circulation, whereas in the 2015 guideline, they have actually revised the thing. They asked to start compression as the first thing, okay? And then you look at the airway, and then you give mouth-to-mouth breathing, okay? All these all these figures can be obtained from the American Heart Association website or their booklet. Okay, let's see. We look at an algorithm of how this patient will present. We've got a patient who is unresponsive to or without a normal respiration. Okay, get immediate help by calling 999. Okay, since it's an American paper, it's 911, but we call at 999. Okay, I hope all of you know what is an AED. It's an automated electrical defibrillation device, which is usually available in many places right now. It is been stored in the big malls. You even have it, the AED device, in the airplane, in the airport. Okay? So what you need to do is you need to assess the pulse first. Okay, first thing is pulse. Okay, you check for 10 seconds. If there is no normal breathing, but the patient has pulse, all you need to do is to provide them with rescue breathing at the rate of 1 breath every 5 to 6 seconds. And this has to be done for every 2 minutes, and then you reassess again the pulse and breathing. If, let's say, the patient has no breathing or only gasping with no pulse, it's a clear indication that you need to start the chest compression. How much of compression do we give? We give 30 compressions, okay, with 2 rescue breaths, 5 cycles. Okay. But we need to be aware that each compression should be an effective, high quality compression, which is characterized or which is denoted by a chest compression, which is a compression depth of 5 to 6 centimeters. There is minimal interruption between compressions. The chest wall is allowed to recoil back to its original position before the subsequent contraction or chest compression is being done. Okay. In an event that you manage to get an AED device in your hand, fit the AED device to the patient, let the machine run the shockable rhythm tracing. The machine will then instruct you if it's a shockable wave then it will advise you on to placing the chest pedals, and then the machine will provide shock and then reassess again the cardiac rhythm. Okay, if there is no shockable rhythm, you need to resume your CPR immediately for 2 minutes and then reassess again. This is done until you've got your paramedic to come help you, or you go into fatigue. As I mentioned earlier, what is a high quality chest compression? It comprises of a compression rate of 100 to 120 compression per minute, with the depth about 5 to 6 centimeters, with minimal interruption between compression and allow spontaneous recoil between compression. What are the don'ts in providing a chest compression? You should not compress at the rate slower than 100 or faster than 120 compressions per minute, as both of these does not provide an effective cardiac output. Okay, a compression of less than 2 inches or 5 centimeters or greater than 6 inches are not advisable, as less than 2 inches will not allow adequate compression between the ribs and the chest wall to pump adequate blood from the heart to the other organs. Or if you're going to compress more than 6 centimeters, there's always a risk of you fracturing the ribs. If, let's say, there is abundance of interruption between compression, you may not be able to achieve this 100 to 120 effective compression during your CPR. Okay. So next, slightly on a what do you call it, advanced note, that I have also included this slide, which I've got from the American Heart Association. It's about an algorithm of adult cardiac arrest. Okay, the first thing that you do is to start CPR. If oxygen is available in your clinic, attach the patient to an oxygen, provide him oxygen, and also put him on a cardiac monitor. And then you need to assess, is the rhythm shockable? Okay, there are only 2 shockable rhythms, which is pulseless ventricular tachycardia or ventricular fibrillation. Okay, a flat line or asystole is not an indication for shocking the patient. Okay, if you have a tracing of a shockable rhythm, which is could be either pulseless VT or a VF, okay, you shock the patients based on the joule which has been recommended with the AED device, or else we can go up to so once the shockable 2 shocks are given, and then CPR is commenced for 5 cycles, and then you recheck again for the patient. If the rhythm is not shockable and there is signs of return of spontaneous circulation, you can put the patient into recovery position till the help arises. Okay, in a patient with pulseless electrical activity or asystole, start early chest compression CPR, reassess the patient's pulse after every 2 minutes. If you have an access to epinephrine, it can be given as an IV boluses, 1 ampule, okay, which equivalent to 1 milligram, given every 3 to 5 minutes. Okay, if let's say during your CPR, suddenly you get a rhythm which is shockable, then you just follow again the shockable rhythm pathway, which is on the left of the screen, or else we just continue as the usual manner till you get a return of spontaneous circulation. I hope you all understand. Okay, just to show you all how does a VT and a VF looks like. Okay, this is the tracing of a VT, which shows a regular RR interval. Unfortunately, you are unable to attain the arterial rate because the ventricular rate usually is between about 150 to 200 beats per minute. So if you realize that there is no P wave preceding any QRS complexes over here, as they are associated only with the ventricular rhythm, okay, the QRS complexes measure more than 0.12 seconds and usually will be wide and bizarre in appearance. Whereas in a ventricular fibrillation, there is no regularity in the shape, is because the electrical activity is so disorganized that the heart just fibrillates. So during this fibrillation, they will never be an effective ejection fraction from the heart to supply the body. The rate appears rapid, but is disorganized. There is definitely no P wave, and there is no clear QRX complexes, and the ventricle complexes will vary. Now we have talked about a patient who's got rhythm which are shockable. What if this patient developed bradycardia? Okay, after a few administration of certain medication or certain intravenous products, the patient suddenly develops slow heart rate, which is less than 50. This also poses a problem. This patient will come with pre-syncopal symptoms. They can have nausea, they can have vomiting, they can have altered sensation, they may have loss in consciousness. Okay, in these patients, when you detect this happening, you need to maintain the patient's airway, assist the patient in breathing if necessary, provide them oxygen. If you have an oral airway, put in an oral airway. Okay, put this patient, hook it up to a cardiac monitor and look at his blood pressure and also his cardiac rhythm. If the bradycardia is causing symptoms like hypotension, altered mental status, any signs of shock, ischemic chest discomfort, or acute heart failure, you can give him a bolus dose of atropine. The atropine is usually 0.5 milligram IV push, and you can safely repeat it every 3 to 5 minutes with a maximum dosage of 3 milligram. If let's say, despite that, you don't have an effective heart rate, then you need to transfer him to a center where they can do a transcutaneous pacing, or they can start him on a dopamine or epinephrine infusion. Right? So you're at your clinic, you just stop at this level, and then get help. Okay, please do not be shy to get help, because that is the most safest thing that you can do for your patient. Again, transfer to intensive cardiac care so that this patient will have a better outcome. Again, when to stop CPR? When there is no obvious signs of life, or you have exhausted yourself. You have been more than 20 minutes of active cardiopulmonary resuscitation with no signs of ROSC. Okay, or a qualified help arises, the paramedic arrives and then takes over from you, or you become exhausted. Okay. Just before we move on, when you are attending the CPR courses or basic life support courses, you will be introduced to certain moulages where you have one rescuer, two rescuer. So I did not include those into this presentation because that is specific to your cardiac life support courses or basic life support courses, which you will be introduced when you are attending the courses formally. Next, we shall move to the management of aesthetic procedure complications. Okay, in this current era, there's so many medications, so many applications, so many things that have been introduced into the aesthetic market. Okay, and introducing such medications, such products to your patient always has a risk of complications. So not everybody will respond to the same way to certain product or medication. So you need to be aware of the product that you're using, what are its contents, what are its potential adverse effects before administrating, and get an informed consent from your patients so that you will not be prosecuted in the court of law in an event some mishap happens. So generally, there are general complications and specific complications. We shall go into one by one. Okay. This is a slide which I've got from the Grand View Research. Okay. This is a market forecast of the global aesthetic market. We are talking about a business which runs in billions, not M in B, US billion. And it shows a linear increase, which is forecasted from 2015 to 2026. And we are somewhere around here, 2022. Okay. So everybody is going and trying to tap into this globally growing market, and in order to achieve the biggest yield or income or revenue. So many players, many industry players focuses on different things. Either they are industry players for devices, industry players for implants, industry players for anti-wrinkle products. All of them are tapping into this market, trying to gain the highest number of income. So we, as the product user or the middle person who actually between the person who produces a device or an implant to the patient, we are the middleman. So they will promise us many different things. They will tell us many different things. So we need to be very sure of what product we are going to use, how we're going to use, and how to ascertain its level of safetiness. So where we stand, okay, all of us are in the Asia Pacific, and we are the region with the highest growth in medical aesthetic device market. So that's why you know that a lot of focus are being shifted, are being channeled in this area. You have many companies placing their local regional headquarters over here to tackle this booming big area, which is the futile, which is the what you call the fertile land for aesthetic market. So let's look. Okay, what are the common or the highly sought after surgical and non-surgical procedures? This is a research based on the American Society of Aesthetic Plastic Surgery, and it is a data which from 2017, just 5 years ago. Okay, so for the top surgical procedures, breast augmentation still holds number one, followed by liposuction, eyelid surgeries, breast lift, and tummy tuck. Whereas in the non-surgical procedures is Botox, filler, non-surgical fat reduction like spool tucking, laser shaping, liposonics, hair removals, and chemical peel. What I would like to bring to your attention is if you look at the number one procedure, which is the augmentation and botulinum, you realize that there is a nearly close to a 5-fold increase in the number of procedures being performed. And all of us know that many patients, I mean, nearly most of the patients do not want to be under the knife, right? They will try to go for other modalities of treatment which does not need them to be under the knife of a surgeon. Okay, you will see this trend growing, ever growing in the next coming years, where non-surgical procedure will dominate in the aesthetic market. So the first thing that you need to know is to know what is the patient's expectation. Okay, what is actually an expectation of the patient? It is seeking to prevent disappointment by establishing in advance what can realistically be achieved. Okay, this is the literary definition by the Oxford Dictionary. So what I would like to say here is you need to make sure that your patient understands what they are looking for and what you can definitely offer them. What you can offer them should be realistic, should be within your capacity to be performed or your credential, and it should be very, very safe for the patient. Okay, you will realize that the aesthetic market, as I mentioned, is ever booming. You have younger and younger patients seeking aesthetic physicians to achieve a perfect appearance. Okay, in the event of in this current era of social media, so many people are sharing so many things on their Facebook, their Instagrams. They have so many followers now with TikToks and everything. People want to look good, people want to look presentable, people want to look themselves marketable, and many people are now doing all of their businesses in the online platform. So your appearance, how you look, how you present yourself makes a lot of difference. So it poses a lot of stress and pressure on this group of people who will later seek for aesthetic physicians to help them out to achieve a better look. Okay, So you'll realize that, once they start coming to aesthetic physicians, they are actually in their mind, they're looking for non-surgical procedures as compared to surgical treatment. So it's a very nice quote by Mark Twain saying that it ain't what you don't know that gets you into trouble, but that is what you know for sure, but it's just ain't so as you think. Okay. So when you have such patients, when their expectations are not met, what would be the sequelae of event? You have a dissatisfied patients who will have high propensity to lodge complaints, to viral you up in their social media, okay, to provide a bad publicity to your clinic, to your practice, even to your credential. And finally, you have a lot of people masquerading over there, scavenging on doctors, putting in medical litigation claims and everything, trying to earn something out of you. So my humble request will be establish the expectations of the patient in the very first consultation. And once again, documentation is one of the most important things. Whatever that has not been documented is considered not being told, not being explained to the patient in the court of law. It may sound silly, but please, is the documentation a thorough, legit documentation is what would be your defense in the court of law. So you need to understand your patient. You need to spend a little more time talking to the patient, looking at his or her expectation at the very first consult. And then you need to do also some amount of psychological evaluation of this patient to see whether this patient is actually in the right state of mind. Whatever he or she is asking out of you, does it sound realistic? Or is it something just the judgment of this patient is clouded by social media or peer pressure, or this patient has some body dysmorphic problem? Okay, all these things has to be established in the very first consultation. All right. As I mentioned again, the media is playing so much role. It's patronizing a lot of celebrity. People want to look flawless. People want to look more presentable. People want to be attending parties. People want to look good in their social media. People want to look good in their TikTok videos. So they always have somebody else that they're trying to mimic or imitate or try to follow. They come, they say, I want to have a lip that looks like Angelina Jolie, or they say they want to have a jaw which resembles some other actor or actresses. Sometimes you need to understand that the Asian facial features may not fit with the Caucasian facial features, and you need to take a lot of time trying to make your patient understand. I know that when you're practicing in a private practice, every patient is your asset. But unfortunately, if you choose a bad apple from the very beginning, it's going to give you a very bad reputation into your practices. It's no harm losing one patient or not attending to a patient rather than losing your entire businesses to all this kind of bad publicity in the media. These are photos that I've got in the internet. Everybody can access. People want to look, as I say, they're trying to emulate, they're trying to simulate to the idol. Okay, so they come asking for things which are not feasible. Sometimes certain things, like maybe the first picture on your upper left quadrant may look quite reasonable, but you need to understand that this transformation from this look on your left to the right, it may not be fully possible just with non-operative intervention. Sometimes you need to do some amount of bony work and soft tissue work. And there's always an issue, when you have a patient with national registration picture looks like this, and suddenly she appears in the airport looking different, you may have problem, identifying this patient's identity. So this poses another problem. And the other thing is, sometimes people can go into a very extreme amount of body dysmorphic problem that they are willing to risk their life in trying to imitate or simulate their targeted idol, right? So as a practitioner, it's most important for you to know the limitation of your practice. What could you possibly offer to a patient? And you need to empower yourself with adequate knowledge and appropriate skills in order to tackle this patient, and also in order to make yourself kept abreast in the ever-growing market of the aesthetic medicine. Okay, next, when we're talking about complications, okay, what I would like to bring to your attention is actually anaphylaxis. Okay? Anaphylaxis is a very common life-threatening hypersensitivity reaction, which is IgE mediated. It not only happens with aesthetic medication, it happens with any other form of injectable intravenous medication that you are introduced the patient to. Okay, there's a long list of medication or products which have propensity to produce hypersensitivity reaction in patients. Okay, you need to know that it is an acute, life-threatening condition which affects multiple systems, and it can also lead to death if it's not tackled properly. Among the allergens which could cause anaphylaxis is food, insect, medication, latex. Okay, so the common allergens which found in cosmetic products. This is what is important to us. Latex from your glove, fragrance which is in your any ointment or creams that you're going to subscribe to the patient, preservative used in this medication, the dye, the chemical, and the metals. So I've given you a couple of examples of what is found to be the common allergen in all these products. These are the other things that which are high risk of anaphylaxis in a hospital-acquired anaphylaxis when you use platelet concentrates, when you use parenteral antibiotics, when you use blood products, or some form of analgesics and also antibiotics. You can go up and look at this journal, Journal of Indian Journal of Critical Care Medicine. It gives you a list of drug-induced anaphylaxis seen in Indian population. You can actually extrapolate this data from this Indian population studies, because our population also resembles something like India. Okay, you still have people of Chinese origin in India, so please bear in mind that it's only Indian, but the Chinese Indian also, right? So I think it fairly represents somehow similar to our populations over here, and we look at things that we commonly prescribe to patient. Maintain also has a causative drug which can cause anaphylaxis, your Voltaren or diclofenac sodium, your PCM, your anesthetic agent like fentanyl, midazolam, propofol, and also your local anesthetic like bupivacaine and lidocaine. So it's always better for you to know what are you using and what are the risks associated with the product that you are using, so that you are well aware of the complications and you're well prepared if the incidence of complication happens. And talking about anaphylaxis, what are the common symptoms? They present with respiratory difficulty, sometimes with hypotension, low BP. They present angioedema with mucosal edema. They also can present with certain GI symptoms, okay, nausea, vomiting, cramping, diarrhea, and sometimes it happens rapidly, immediately after the contact to the allergen, but sometimes it can also present later or biphasic. Sometimes there will be a problem in elderly patients on beta blockers. They may not exhibit all of the symptoms despite having anaphylaxis reaction. So you may be caught off-handed. So these are the the symptoms that they can present with anaphylaxis. On skins, if it's quite common. This is what always we look for, whether they present like hives, swelling, itching, warm redness, whether they're wheezing, they have shortness of breath, complain of chest tightness. This chest tightness could be because of anaphylactic reaction. It also could be because the patient is having a cardiac arrest. Okay, they can have changes in voice, hoarseness in voice, nasal congestion. You can have nausea, vomiting, stomach pain, cramps, diarrhea, and all the others. So how do you treat them? Okay, follow guidelines. Okay, this is the latest guideline which is reviewed in 2016. Okay, what we give first, you need to establish, and the criteria to establish anaphylaxis is it is sudden onset with rapid progression. There's a life-threatening airway or breathing or circulation problem with skin or mucosal changes. Okay, and you need to establish this is after or following an exposure a known allergen. Okay, but you also need to know skin and mucosal changes can be very subtle or absent in about 20% of patients. All right. And sometimes people may not be presenting with skin or mucosal changes, they just come with GI symptoms. Okay, even then also you need to have a high index of suspicion whether this patient is developing a anaphylactic reaction. What are the differential diagnoses of this condition? They can either be because it's an asthma-like presentation, they can come with low BP, a particular reaction, which because of septic shock. Sometimes this patient may have some form of infection going on, but they do not inform us. They come and take treatment from us, and then you realize that you have given a fairly safe medication, but then they develop all these rashes and low BP. So then you need to have a very high index of suspicion to see is there any abscesses somewhere around this patient. These are the life-threatening condition which mimics an anaphylaxis, whereas the non-life-threatening condition which mimics anaphylaxis could be just a vasovagal attack, a fainting episode, a panic attack, or an idiopathic non-allergic urticaria or angioedema. So, what we do, again, we have an algorithm. Establish whether it's an anaphylactic reaction. Yes. Look at the airway, breathing, circulation, disability, and exposure. Call for flap, and then lie the patient flat with the raise the leg so that you increase the venous return. The medication that you use, the life-saving medication over here is adrenaline. Okay. How much of adrenaline? In an adult, we can give about 500 micrograms, equivalent to 0.5 ml. You can give it as an intramuscular or a intravenous administration. Okay. This algorithm also gives for children less than 6 years, more than 12 years, 6 to 12 years, or less than 6 years. But I don't think this is important for our discussion today in this particular topic, because I'm sure you won't have a child less than 12 years coming in for seeking aesthetic treatment to you. Okay, establish an IB access, give him fluid challenges, and then we also can give them, because it's an IgE mediated whereby histamine is released, we can also provide them with antihistamine and some steroids. Okay, steroid of choice will be hydrocortisone. Okay, usually these are self-limiting, okay, but it is safer to transfer the patient to an ED because he or she requires an overnight monitoring so that the patient does not develop a biphasic reaction, and the patient is monitored for at least 24 to 48 hours before being allowed to be discharged. And this patient should also carry with them their anaphylactic or allergic card, and it must be presented to you every time. I mean, make it a habit to ask the patient whether this patient is allergic to anything. Does he have an allergic card or an allergic chain or an allergic band with her or him before you institute any treatment. It's wise to be safe than to be sorry. Again, it's just a zoom up of the dosages. So what is an adrenaline? Or also it's called as an epinephrine. Okay, it has both alpha and beta adrenergic receptor agonists. Okay, it works with the mechanism. It causes systemic vasoconstriction. It produces GI relaxation. It stimulates the heart to pump faster. It dilates the bronchi so that your respiration becomes better. And it also dilates the cerebral vessels so that you have enough blood, brain perfusion. The reversal of the peripheral vasodilatation and to reduce edema is taken care by the alpha component, and it is preferably an IM margin. IM is preferred because it has a high margin of safety, and you can inject anywhere around the middle third of the thigh or the anterolateral thigh. And you must make sure that you use a sufficiently long needle to ensure it is into the muscle, not into the subcutaneous tissue. Because if you inject to the subcutaneous tissue, you realize that it will take longer to produce reaction, because from the subcutaneous tissue, it has to get transferred into the blood before it can affect its it can exhibit its mechanism of action. Again, 0.5 milligram, 1 in 1,000 dilution. You can repeat every 5 minutes. As I mentioned again, you may have failure in treatment of with adrenaline epinephrine because if the patient is on beta blockers, because these are both alpha and beta adrenergic receptor agonists. So you've got a beta blocker sitting down there in the receptor, so it only functions at the alpha subunit, whereas the beta subunit does not have any effect. Those patients with an established anaphylactic reaction, maybe they have allergic reaction or anaphylactic reaction towards pollen, towards certain nuts, towards certain chemicals which are available all around them in the environment. It is advisable for them to carry a pen-filled epinephrine like this. You just have to break the cartridge and inject. So this could be a life-saving device, and you can also keep this in your clinic if it's available, because you don't need to draw them up. It's already pre-filled, and then you can immediately use to your patient. So other things that you can give as a supportive for this patient will be bronchodilators, either in the form of salbutamol, ipratropium bromide, aminophylline, or magnesium sulfate. Other cardiac drugs is better to be given in the ED, like atropine for bradycardia or inotrope. You need to start inotrope if it becomes worse. Okay. Now, I think we're going quite fast. Okay, I hope we can finish it early so that you all can get your classes done early. Okay, now I'm going into the specific complication. Okay, fillers. I'm sure that the subsequent slides will be there. It will be a repetition for you all. As you go through the classes for individual intervention, fillers, Botox and everything, the lecturers will be talking in more detail about the complications. So I will just give a glance through, okay, like a preamp for your future classes, no? Okay, what are fillers? Fillers are gel-like substance which we use. First is to restore volume. Once the volume is restored, those fine lines of wrinkle will be smoothed out. The creases will be evened out, and in overall, it gives a plumpy and a very rejuvenated appearance to the area that you're going to tackle. So commonly available in the market are now mostly a hyaluronic acid based, but in some countries, South American countries, they still use calcium hydroxyapatite, poly-L-lactic acid, PMMA, autologous fat. Among all these things, I think the safest are still the hyaluronic acid in autologous fat. So these are the indications, you're trying to sort out or to address the contour deformity of the forehead, trying to fill up the sunken area of your temple, okay? Also your around the periorbital area, especially on the lower eyelid, give a higher malar projection, define the cheeks. You may want to soften up or smooth the nasolabial groove, sometimes become very deep. Also, the marionette lines around the mouth and chin. Example of brands, we have Juvederm, Restylane, Boletro. And for hydroxyapatite, we have Radiase or the Sculptura using a polylactic acid. So the complication could be either divided into an early onset, late onset, or delayed. Okay, it's based on the timing. If it's less than 14 days of administration, we call it early complication. If it's after 14 days to a year, it's called a late. And if it presents after a year of injection of fillers, it's called a delayed. Okay, so usually there are, in the early one is injection site reaction. You have erythema, redness, swelling, and all those things. These are usually because of improper technique, improper depth of injection, or giving high or large amount of liquids in one particular region. Okay, in some patients, they may develop allergy or hypersensitivity to either ready hyaluronic acid, but usually to the preservative in it. And sometimes your inadvertent injury happens or complication happens when you inject them into the vascular component or vascular compartment. So this is a journal published in 2010 they give you a nice table on the what are the things that you look for, early complications and delayed complications. So as I mentioned, what you get on the injection side is pain, edema, erythema, bruising. After injection, injection, this patient, they prefer to do all this non-invasive procedure so that it becomes an office procedure. They come, get it during their lunch break, and then get back to work without anybody realizing. But in an event that you have all these complications, the patient has to be away from work or away from whatever activity that she's been doing, until this thing resolves. The most dreaded complication is actually intravascular injection. Okay, common area that we are so worried of this complication is around the periorbital area, whereby there could be an embolus into the ophthalmic artery and causing what you call an arterial embolus into the retinal artery, and then the patient can develop immediate blindness. Okay, sometimes if you're injecting to the marionette line or the nasolabial fold, when you have the angular artery or the facial artery, you inject to any small branches of the facial artery. Let's say if the branches is going to your upper lip, and you realize that the patient comes with severe pain, whitish skin discoloration, because there is no arterial flow, and this artery is already embolized with this filler material. If the fillers gets into the venous circulation, this patient will present with throbbing, dull, aching pain. So this is an example, somebody inject to the periorbital area. It is just local reaction when you have erythema, edema, swelling. And over here, possibly on the glabellar region, they have an intra-arterial injection of the fillers. This is just another common complication, after injecting to increase the volume of the lip, right? So how you tackle this thing? First is to prevent. How do you prevent it? You use appropriate technique. Use small needle, provide adequate analgesia during the procedure, cold compression so that you provide vasoconstriction so that you do not inject into the muscular compartment. And sometimes to give patient more comfort, you can also give nerve and regional block. In patients who are prone for what we call this bruising, make sure they stop supplement like ginkgo, vitamin E, omega-3 or ginseng, which is common in our Asian population, because this can cause bruising, very bad bruising. Okay, and avoid vascular area. For this, you really need to know the anatomy of the area that you're going to be using your fillers. One important physics phenomenon that you see with fillers is Tyndall effect. Okay, what happens? Tyndall effect is actually because of scattering of the light by particles in a colloid suspension. that the skin around the periorbital region is one of the thinnest skin available in the body, and you put a filler into those thin area. Those area with atrophy of your dermis, when you inject it too superficial to the skin, because of the ambient light, it gets scattered into the particle inside your fillers, and then it presents, the reflection of the light appears like a bluish hue, and then it looks like the patient as if has been punched onto her eyes. All right, so why it happens? Because you inject the fillers too superficially, common in tear trough areas, and the skin is too thin because of previous treatment, either because of too much of steroids, or the patient has the genetic condition where the patient's dermis is very thin. When I zoom this picture, it looks, you don't see what is it. What I meant to show is the Tyndall effect is over here. A very, very fair skinned person with a filler onto the intraorbital area, which presents as a bluish hue. And this could be very troublesome because it stays there as long as the filler is still there. So we know fillers are not permanent. They get dissolved with the body maybe 6 months to 8 months. So she has to live with it for the next 6 to 8 months. Okay, the other option is, you may think, shall we remove it or shall we use a hyaluronidase? It depends on to the judgment of the aesthetic physician, which will provide the patient the best of care. Again, these are the examples. Sometimes, if you inject large volume to one specific area, it forms a nodule. Okay, so especially over the lower eyelid and the nasolabial fold. So sometimes, if during your injection you realize that you can maybe try to aspirate, but if the nodule is hard, then it's very, very troublesome for the patient. You can also provide incision and drainage to remove that particle. If it's large, the use of hyaluronidase. Hyaluronidase is actually an enzyme that breaks down hyaluronic acid. So this could be also helpful. For other fillers like PMMA fillers, okay, usually used for deep static folds, acne scars, leg augmentation, dorsal augmentation. They present as persistent redness, itchiness, hypertrophic scarring, or lumpy nodules. So in such patients, when you have those complications, local corticosteroid injection has been proven to be helpful. You need to massage, and then sometimes you may also put them onto oral steroids. So these are examples, the lip fillers, very lumpy appearance, it's not smoothened out. So sometimes if it's delayed presentation, it could be inflammatory, but if it's not, usually it's not if it's immediate, it's non-inflammatory. If it's delayed, it's inflammatory, or sometimes in delayed or late, it could be infectious in origin. So treat them accordingly. Okay. If let's say the lumpy non-inflammatory lump persists and that area has been over-treated with your fillers, needle aspiration or minimal step wound using a blade 11 size blade, and you expel the fillers out. Okay, or sometimes you can use about 150 units per ml of hyaluronidase to enzymatically degrade the hyaluronic acid. And if let's say this patient has developed some post-inflammatory hyperpigmentation, then you may use depigmentation cream, or you can use lasers to treat the condition. Okay, this is a graph guideline of how much you can use in these regions, how much of hyaluronidase that you can safely inject to treat these complications, right? As I mentioned, vascular compromise is the most dreaded complication. As we know that the face is actually a very vascularized organ in your body, and it has many small blood vessels. Okay, inadvertent injection into this vascular component can cause thrombosis of these end arteries which supply the dorsum of the nose, the tip of the nose, the columella, or sometimes over the glabellar region, over the eyelid. These are the examples of people who come, people inject into the supratrochlear or supraorbital artery, into the angular artery, or the worst still is from the lateral injection to the nasolabial fold. Some of the fillers escape and get into the lateral nasal artery. Some travel through the angular artery into the supraorbital artery and then into the ophthalmic artery. Once it gets and it blocks into the ophthalmic artery, you can develop sudden blindness. This is one of the most dreaded complications of fillers, right? So the possible areas of injection which could lead to this complication is addressing your nasolabial region or into your supratrochlear or supraorbital artery, where you try to tackle the glabellar lines. Okay. It presents as an excruciating pain with sudden loss of vision. So in these patients, you need to reverse this condition within the first 60 to 90 minutes in order for you to restore the vision. So what needs to be done is you need to inject your hyaluronidase about 150 to 200 units into the retrobulbar space. And bear in mind, please do not do it yourself. Please refer him to an ophthalmologist because they are more familiar with giving a retrobulbar injection. Okay. Now, I mentioned earlier about end arteries, with the terminal arteries with no collaterals. So the region which are prone to develop complication, to show tissue necrosis, will be the globular region, the distal region, and also the periorbital region, and sometimes the temporal region. So while injecting or addressing fillers into these areas, be aware of all these arteries that's available. And then, as I mentioned, you can take many different ways, use a cold compression, constrict the arteries before you're going to inject. Or if you know the known source artery, you need to compress that artery, inject, wait for a while, and then only release. All these things, and always, what do you call this? Once you have introduced your injection, before injecting, pull out, see whether you are in the vascular compartment. Check and recheck always. Okay. So common way of managing is stop the treatment, massage, warm pack. Hopefully the body will eat up the hyaluronic acid particles if it's small enough. Or sometimes if it gets blocked, you may need hyaluronidase. And if, let's say, you have wounds like this, I think it's better to refer to plastic surgeon, because we may need to do certain debridement and then flap reconstruction. So again, these are the strategies: aspirating prior to injection, utilizing low volumes with serial small aliquot injection, treat one side at a time. Okay, tenting of the skin, manual occlusion of the origin of supratrochlear vessel in non-dominant, and blunt cannula may reduce inadvertent introduction into the vascular compartment. Okay, this is a paper by Rorich. Rorich is actually the current editor-in-chief for PRS journal. So I've given you the DOI number. It's a nice paper to read, and it gives you an algorithm of how to practically approach and the safety of hyaluronic acid fillers. Okay, so I suggest you can use this as your guideline on how to treat the complications. Next, moving on to botulinum toxin. Okay, we have got so many products of botulinum toxin marketed under the name of Botox, Dysport, or Xeomin. So usually it is used to paralyze certain group of overacting muscle so that it evens up or contours up the creases. So usually used in the globular lines for forehead wrinkling, periorbital or perioral line, or to paralyze the platysmal band, to reduce the masseter lines. Okay. So these are the pre and post pictures. You realize that you have in a patient with injection of this Botox, it paralyzes the frontalis muscle, all your corrugators, your facial expression muscles. So this patient will have a very mask-like faces. So it appears that the skin is very tight, rejuvenated, but then the expression will be compromised. And this lasts up to 6 to 8 months. So if you wrongfully or you overtly paralyze one group of muscle, and you will have this kind of problem. You have one side of the eyebrow is higher than the others, and this patient has to live with it for the next 3 to 6 months. Prior to using a Botox, it is advisable you need to rule out all these neuromuscular disorders, and you have these disorders. I would suggest please do not use Botox in these patients. So this is a table showing the list of complications. You can have sensory disruption, you can have halitosis, pain over the injection site, edema, bruising, hematoma, or facial pain with different dosages of botulinum toxin A. Okay, this is a complication. Right. Looking into it, they also present with short-term hyperesthesia over this region, where else the non-injection site complication could be because of improper placement or diffusion of this toxin into an intended adjacent muscle. So before embarking on Botox, you need to know the appropriate technique, you need to know the anatomical knowledge, you need to know exactly how much volume you need to use, And to allow diffusion, please do not make the patient lie down after the procedure and do not massage, as you will disperse the toxin to other neuromuscular junction and cause sick paralysis. This is the bigger market on devices. You have lasers, intense pulse light, ultrasonography, radio frequency devices, which are available in practically all the aesthetic clinic and established aesthetic practitioners. They are fairly very safe, but they cannot you cannot rule out that complications do happen if you do not use them properly. Okay, since these energy devices releases high amount of heat, okay, it induces some form of tissue injury to restart again the wound healing process. So if it is not used according to the calibration and the recommendation of the provider, you can produce burn of varying depth. And it also, patient can present with post-inflammatory hyperpigmentation as a result of the usage of these energy devices. Sometimes while using these energy devices, the operator are also exposed to certain form of hazard, especially the smoke from using a CO2 lasers. If you're using a CO2 laser to a warty lesion, there is a risk that the EBV virus, the herpes virus in the wart being aerosolized, and then you inhale this carcinogenic or viral particle into your system. Or sometimes, if you are not very careful using ablative lasers, you can injure yourself also while doing the procedures. This is an example. Usually post-inflammatory hyperpigmentation is a very big problem among pigmented patients, especially patients in Asia who has got skin type Fitzpatrick 4 and 5. They are more prone to have post-inflammatory hyperpigmentation. Okay, it could be a very difficult situation to handle. You need a lot of other treatment, and sometimes, certain residual hyperpigmentation cannot be addressed. So in order to prevent post-inflammatory hyperpigmentation, you always advise the patient to apply sunscreen, sun protect. Sometimes you can try bleaching, hydroquinone creams, tretinoin creams, some lightening treatment like with topical gel. In certain areas, you can actually try chemical peel, but it all depends on the patient's skin type, right? Finally, the least damaging is camouflaging makeup. You only aesthetically camouflage those areas of hyperpigmentation, but once the patient is off her makeup, you can still see the effect of PIH. In order for you to have lesser amount of complication, you must know exactly what are you using your energy devices for. What is your targeted chromophore? Whether you're targeting the hemoglobin, whether you're targeting the water, whether you're targeting the melanin. Okay, based on that is when you know what you are going to do, what you're trying to achieve, that's when you get the best outcome and you reduce your risk of complication. Always provide a test dosing first for your patients for lasers. Test on a small area, give it a good 6 weeks to 3 months, reassess again how the skin responds to these energy devices. Do they produce PIH symptoms? If let's say the patient is able to follow all your post procedural advices and then the patient has no PIH, then you can embark on your subsequent series of treatment. Okay, appropriate energy delivery, with regards to its joule, with its fluence. Okay, cooling of the superficial skin to prevent deeper damages penetrating into the dermis. Okay, again, sunscreen and post laser advices. I think this post laser advices or sunscreen is in fact post good for many of the others. Even in our patients post surgery, post burn surgery, post scar revision, we still do advise them on sunscreen, ask them for scar massage, all those things. So this, by many clinic they tend to hire beauticians to do this chemical peel for them. It's a form of chemical exfoliation using various kind of acid with different strength, which causes epidermal and dermal insult in order for you to jumpstart a wound healing and laying of new collagen particles so that the patient will get a rejuvenated look. So while using this chemo exfoliant, okay, immediate reaction you see is pruritus, burning, irritation. So this is quite common. The patient needs to be aware of it. But my worry is when you use it onto areas, especially around your periocular region, it inadvertently, if you do not use the right strength, you can cause deep burn to your eyelid skin. Because the eyelid skin is the thinnest skin in the entire body. So if you cause any damages to it, the scarring could be very, very bad. Some present in a delayed, you have the loss of cutaneous barriers and tissue. So what happens is the infection sets in. You're worried about hepatic, candidal, fungal, or bacterial. Okay, some patient with an abnormal wound healing, they develop scarring. Some patient, all this erythema, this blistering of skin does not heal well. They will be delayed in healing. Some patients, when you have the healing taking place with overgrowth of your sebaceous gland, you develop milia. Okay, some patients develop hyperpigmentation. Some people develop hypopigmentation, and some patients develop demarcation lines. All right. So need to be aware of all these things and then treat them accordingly. So I think that's all I have for your presentation today. Thank you very much for your attention and time. Do you all have any questions? Okay, anyone? Do you all have any question? Okay, I will start with Sharifa Nurdura. Can we cause large hematoma post fillers? Okay. Usually you can. Okay. When it happens is when you inadvertently injure the vessel, and these patients are on blood thinning agents. Your compression doesn't work. Okay. So there could be any form of blood thinners, whether this patient like on ginkgo, vitamin E, all this supplementation, and some patient may be on aspirin for any reason, or some antiplatelets for any reason. So you can have these complications. So it's important for you to know the patient's medical history and what drugs they are on in order for you to prevent that. Okay. The next question, apart from pain, what are the other symptoms or signs that could point towards vascular occlusion? Patient might not be feeling pain due to analgesic. Okay, where after injection, you need to look at those areas of injection. If the area becomes whitish, okay, there is no capillary refill, okay, then you know you have inadvertently inject into the arterial circulation. So you may need to provide compression, warm compression, reassess the patient again, within half an hour or 45 minutes. Once the effect of your analgesia has weaned out, that will give you a sign of whether you have injected into the vascular component. Question number 3, how do we differentiate between hematomas and vascular occlusion? Especially if the patient is consulting us from home a few hours after fillers. Perhaps they're telling us that having pain, skin changes. How do we go about that? Okay. Hematomas are swelling, you can see, but as vascular occlusion, the hematoma, there are two types, whether it's already an established hematoma or growing hematoma. You'll realize that at the area of injection, you develop a swelling or a lumpy appearance which slowly increase. That is because of hematoma. Vascular occlusion is they will get a very bad throbbing pain because it's an arterial insult. It can cause ischemic pain. So you need to establish that. I would suggest rather than doing a home consultation, get the patient to your clinic back again and then assess it yourself. You know, sometimes you may not be able to take whatever your patient says because they're not medical personnel. So what your interpretation of vascular pain as compared to what the patient's interpretation of pain will be different. All right. I hope that answers your question number 3. What happens if we give hyaluronidase in patients with hematoma and not vascular? If you're going to give this patient for hyaluronidase in a patient with hematoma and not vascular occlusion, it's not going to give you any added benefit because the hematoma is actually the blood which has seeped out of the vascular compartment. So it may not provide immediate or near immediate resolution of the symptom. Usually the hematoma will get washed, will get liquefied within the 5 to 7 days. Okay. Whereas if you allow that to happen in a vascular occlusion, you can get tissue gangrene at the end of 5 to 7 days. Okay. Would you refund if complication occurred? Uh, it's a very, very ethical questions. By right, rather than giving a refund, I would suggest you treat the complications. Okay, it could be very messy if you're going to refund because why? Then they will blame it onto you, saying that you conveniently refunded because you didn't know what to do and you are not safe. But if you keep the patient in your radar, treat the complications, make sure you establish your rapport with the patient and the patient trust in your care, I think the patient will be very happy. Okay, what do I mean by post-demarcation mark after a chemical peel is, if let's say you're going to do a chemical peel over the face, okay, but around the periorbital area, you did not use a lighter agent, you just leave it blank. Then you realize that as if there is actually a watershed mark which demarcates the area that you've been treated and not treated. So that's a question by Shaira Asila. So I hope that that answers the question. You all have any other questions? Any more questions? Okay, since I don't think there's any more questions, I think I will pass over to our MC.